Good afternoon, everyone. I'm Michael McGilly, one of the fellows at Minneapolis Heart Institute and Anatomical Healthcare. So I'll be presenting overcoming challenges of DK crush. And here are my disclosures, a little bit fewer than Dr. Boulakis, but our patient is a 71-year-old man, came in with progressive angina. He has a history prior CABG, and on the coronary angiogram done in outside facility, he had a patent lima to LAD and patent radial grafts to both OAM and PDA. So he was referred to us for complex PCI. And you can see in this image here, we have him left main medina 111. And despite that, the LAD is protected distally, you can see here, oh, that's not playing. You can see here that there is limiting flow to the LAD and do large diagonals. So our next question was a strategy, and this is the algorithm we used. We have a bifurcation lesion, and we need to preserve the side branch, which was a large circ. So we had a high likelihood of side branch occlusion because of the amount of disease at the bifurcation. And because the angulation was less than 70 degrees, we decided to go with DK crush. So we used the femoral access, we got a long sheath, and we had our first challenge. We could not engage using even a view 3.5, 4, 3.75, and mostly because of the superior takeoff of the left main, so it could reach, but it would not just sit right. So what did we do? So we used the GL4, and then we engaged the left main with the shown blue, then we exchanged it to a Grand Slam through a Caraval. So now we have a Grand Slam that can be used as a rail, very stiff wire. Over it we advanced an 8 French ABU4. Now we have the guide and we're ready to proceed. And then we had our challenge number 2. As you can see, severe disease in the LAD. Tried multiple wires to engage the LAD, but it was very difficult. We used a shown blue, a SU3, even used a Caraval and a Fielder FC that could not pass. So what do we do here? So we decided to use a dual lumen microcatheter, and we use a twin pass in this case, and I'll let this play because this looks pretty cool. And we could pass to the Fielder FC, and now we have access to the LAD. Then we exchanged the Fielder FC, the polymer ejector wire, to a shown blue workhorse wire. Then, as we always do, we saw calcification in the circ, so we decided to go with IVUS to assess this calcification. And as you can see in the IVUS, the calcification is not circumferential, so we decided not to proceed with atherectomy this time. And this is just a quick representation of the DK crush procedure that we'll go throughout the case. So we started with predilation of the main branch and side branch. We used the 2.5 balloon. We used the 2.5 and 3 NC and an angiosculpt 3. And then we had our challenge number 3, the large dissection in the circ. And because we had access, we had our position, so we decided to proceed with the DK crush as a best management of this complication. So we got a 2 ODS in the circ, post-dilated with a 3 NC. And then this was followed by crushing with a balloon that was already parked in the LAD. And then we did some dilation of main branch, which is equivalent to a pot, but we don't have a main branch stent, so we dilated the main branch to help us recross. However, we still had the challenge number 4. We could rewire the side branch, we could rewire the circ, but we failed to recross with equipment to side branch. So what we do is rewire again to make sure that we're in true lumen to true lumen, and we're in the right strut. So we tried rewiring multiple times using dual lumen microcatheter and a Fielder FC. We could rewire, but we could not pass a 2.0 balloon. So what we did at this time, we used a very low profile Sapphire 1.0 balloon. It has much lower crossing profile than most of the balloons. And then, again, I'll let this play because I think it's cool, and finally passed, dilated, and then we could follow it by a 2.0. Dilated again, and then we did simultaneous ballooning, and the first kiss was done. After that, we followed it by an LED stent 275, sized for the distal LED, and then followed by pod, dilation of the proximal main branch stent, and then we could do the second kiss. And we followed that by IVUS to assess the stent that was placed in the circ. We saw some mid-stent under expansion that was post-dilled with high-pressure balloon, and then we had good outcome. This is our final result. So in conclusion, when you have trouble with engagement, a diagnostic catheter and a step wire can be your friend. You can use the wire as a rail. In left main bifurcations, IVUS is a must, and meticulous lesion preparation as well. Specifically for DK crush, failure to rewire, pot might help, twin pass might help, and of course a polymer jacketed wire. And when you fail to recross, rewiring with a lower profile balloon could be very handy. Thank you.
Great, thanks, Mike. I guess that illustrates the concept of no pain, no gain. DK crushes can be a fairly complex procedure to do. Any questions from the audience?
We exchanged over long Grand Slam, yep, at 260.
Yeah, so essentially this maneuver, diagnostic goes in, then the Grand Slam or Ironman or Wiggle, whatever you want, goes in, and then over that, it's a long wire, get the diagnostic out and the guide goes in.
Thank you.
All right, thank you very much, Mike.